First of all, I'd like to thank to Sami for this kind of invitation. So I'll talk about the new concept in spinal deformity corrections. First of all, in the past, it was difficult to operate these kind of spinal deformities. Nowadays, they're still difficult, but there are some things that we can do to make it much easier. So start from the pediatric cases. The specialty of these cases are that you have to try to prevent the progression of the curve, but also you have to let the spine to grow. So if you fuse these pediatric cases in very young ages, you may prevent the progression of the curve, but at the same time, you reduce the thoracic volume and you decrease it. So it eliminates the growth potential. And also the early fusion decreases the force vital capacity. So there are techniques that we can use as the growth-friendly techniques. So there are lots of growth-friendly techniques. I'd like to talk about the growing growth technique. So in this type, you apply a growing growth. It can be a mechanical or it can be a magnetic control growing growth. So you need an X-rays to determine the instrumented levels. So this is a case that we have applied a growing growth, and this is the device. And the thing that you're doing, the idea is first you do the first surgery, then in every 6 months or in every year, you follow up the patient, and in the operation, in the outpatient clinic, you can increase the length of the rope there. So the only thing that you have to do with the helping of this device, you distract the length of the rod here. So you find the rod's place, and the only thing that you have to touch the device, and you increase the length of the rod here. So another thing that we're doing nowadays is the hollow traction gravity. So this is the postoperative, the first day of the patient. So you see it's working now. The patient tries to use it. So in which cases we use it? Especially in the patients that we need to increase the volume of the thorax, we use it. So we do it with the local anesthesia. At the beginning, in the first day, we started at the 10% of the patient's weight. Then we increase it step by step. The aim of the traction has to be 50% of the patient's weight, and we apply it for 1 or 2 months. So the patient is using it while the patient is lying, sitting, and also standing. And in a few days, you see the patient adapts the device very easily. They use it for 24 hours. So does it work? It really works. This is the measurement of the patients before the traction, and these are the measurements of that patient after hollow traction. It increases the vital force capacity, and in some cases, which is not possible to operate, after using the hollow devices, you can get this patient in the operation. And also in the literature, it says that with hollow traction, you can reduce 10% of the scoliosis curve. Another thing that we're applying in these patients, I showed this case at the beginning of my presentation. While you're tracking these patients, also you get these patients to the physiotherapy. And if you get more muscles, you will have less problems of the head of the screws after the surgery. So with hollow traction on physiotherapy and the increase of the volume of the muscles, you can operate the patients, and this is after the operation. Another thing you may have during the surgery, especially in the congenital cases, especially patients over than 20-25 years old, you may have lots of cardiac problems, even you have it in the very young ages. This case was a congenital case, 25 years old. So in this case, when we get this patient in the prone position, we get a bradycardia. So we had, before the surgery, we had cardiology consultation, we got the echogram, but we had that problem. Again, we had consultations again. Then in the second, at the beginning of the surgery, when you change the position of the patient to the prone position, you get bradycardia. And in the second beginning of the surgery, we had a cardiac arrest. So at the third, so we tried to use a pacemaker during the surgery, and we could finish the surgery, started the surgery, and after finished the surgery. So using a pacemaker during the surgery will be fine, especially if you have a problem in the congenital cases. So there are also some, not revolutions, but some tricks and tips to operate the adult degenerative cases. This is a adult degenerative scoliosis and also kyphotic patient before and after the surgery. So what can we do in this type of cases? This is an ankylosing spondylitis case, another case. So we're having some measurements also in the sagittal plane. I use SurgeMap. So it allows you to plan your surgeries before the surgeries. So in a case like this one, you get the sagittal parameters before the surgery. This kind of software helps you to plan before the surgery. In this case, the patient has a severe sagittal imbalance. So you get the idea. Let's say we try to, if you do a type 3 osteotomy at L4 level, what kind of a sagittal balance that you're going to have, you can measure it before the surgery. So this type of surgery at this level will be not enough for that patient. So adding a type 2 osteotomy, I mean a Ponti osteotomy, will be again not enough. So we skip to corner osteotomy at L4, and we have added 2 levels Ponti osteotomy. So if you look in these measurements, we know that these type of osteotomies will provide a good sagittal balance. So another advantage of these softwares, you can also measure the length of the rod here and also the shape of the rod here. So according to the literature, let's show this figure here. If a patient is older than 74 years old, the difference between pelvic incidence and lumbar lordosis, if it's 17 degrees, it will be enough for you. So we measured it here. The pelvic incidence was 57 degrees and lumbar lordosis was 39 degrees. So if we get a difference between pelvic incidence and lumbar lordosis, let's say 17 or 18 degrees, it will be so if I can get a lumbar lordosis, 40 degrees lumbar lordosis after the surgery, it will be fine for me. So you can measure also the length of the rod here. So this is the shape of the rod. So I know that the lumbar lordosis and the length of the screw before the surgery. So this is a custom made, a pre-bending rod here. So we bended it before the surgery. It gives you the advantage to not spend time during the surgery. And also, if you can put easily this rod during your surgery, it means you have the proper shape. So you have to bring the spine to the rod without using any forces. So this is the intraoperative view of that patient. So this is the two separated parts of the CR. We get an upper part of the lumbar area and also the sacrum here. So I know.
That's nice. That's good.
Sorry. So if you get a 39 degrees lumbar lordosis, now so I know that this lumbar lordosis will be fine after the surgery. So this was before the surgery. This was my planning, and this is my after the surgery. So these are the clinical photographs of that patient preoperative and postoperative. Another case, again, a lumbar degenerative scoliosis, adult degenerative scoliosis case, back pain and bilateral leg pain. Again, in this case, we can measure the sagittal parameters so that we can make a good plan before the surgery, which type of osteotomies that we need and at which level and which type of osteotomy. So it is decided to make an corner osteotomy. We call it as type 4 osteotomy. They measure it before the surgery, so they applied it. So these are the clinical and radiological X-rays of the patients before and after the surgery. So we achieved a good sagittal balance here. Another case with, again, elderly age patients had a previous lumbar disc surgeries and instrumentation. The patient has not a good sagittal vertical axe because the patient was using as pelvic tilt. So the patient tries to compensate it. So we again used pre-bending custom-made rods here. These are the intraoperative views. In these kind of surgeries, we use a T-shaped rod here to maintain the coronal balance here. So these are the parts that we get AP views of the C-arm. We combine it during the surgery and we see if we have a good coronal balance or not. So L3 and L4 are parallel to the floor before and after the surgeries, patients, X-rays and clinical photographs. So another thing that we can use during the surgery is kickstand rod technique. We use this technique to maintain especially the coronal balance. So if you look only at the lateral view, the patient has a good sagittal balance, but if you have a severe coronal imbalance, like in this case, this was my first case that I have used coronal imbalance, kickstand rod technique. I applied this technique wrongly. So what I have done, I changed only the position of the screw here to increase the forces, the distraction forces here. So this was before the surgery, after the surgery and revision surgery. So this is the technique. You put an extra iliac wing screw here, then you put an extra rod on the coronal imbalance side, then you put a strongly rod holder, then you distract it. So this is the technique that we apply during the surgery. So this was the case, my first case that I revised it here. So make it short here. So we change the direction of the screw here. Then we put an extra rod here. Then you fix the head of the screw that you have inserted it in the iliac wing here. Then you put your extra rod here. You connected the extra rod with the helping of a domino here. You fix it. At the same time, you lose the head of the screws here. And with the help of a strong rod holder, the only thing that you have to do is to distract that rod, and it helps you to maintain the coronal balance here. So this was after the surgery. Disadvantage of this technique, if you look on the sagittal plane with this distracting forces, you maintain the coronal balance, but with this distracting forces, you lose some sagittal balance here. So you are increasing the sagittal vertical axis here. So to prevent this disadvantage, let's say you have applied a kickstand rod on the left side. You balance the spine, but you lose on the sagittal plane. Then you have to put add an extra rod on the other side. And if you use a compressor, you can bring the spine back. And this technique is known as Tyrotechnic. So after the first case, we started to use double rods, kickstands combined with Tyrotechnic to maintain the Kernel balance here and also the sagittal balance. So these are another cases, intraoperative use here. So another thing that we have now, in the past we didn't have it. Now we can use augment also the navigation systems in rotated spine or in very severe spinal deformity cases. So it really helps you to see the pedicle directions in coronal, sagittal, and also in the axial plane. If you have the chance to use it, it's very useful and it helps you, and also it decreases your stress during the surgery. So there are lots of things to talk about, let's say, revolutions in spine surgery, but I think in the future, custom-made devices will be used more common. Especially minimally invasive deformity surgeries will be very popular. Dynamic systems will be, I think, will be more common, and I think the technology will be more helpful in our surgeries. Thank you so much for your interest.